This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast. Okay, welcome back to the Alert Medic 1 podcast, everybody. Today we're going to have on the Maryland State Medical Director, Dr. Tim Chizmar, and we're going to talk about the Maryland State Protocol updates that are coming later this month, effective July 1, 2024. So if you're not a Maryland provider, I understand this is not going to totally apply to you, but I'm sure there's something you can take away from it. And if you're looking to do some improvements to your own protocols at your agency, state, whatever, maybe you can take something away from this, or just learn maybe the method behind the madness of something that you guys are doing in your own agency that is similar. So to lead it off, where do we want to start? Do we want to start with the big hitting topic of the new algorithm, or do we just kind of want to go line item by line item?
Well, Dr. Chizmar, do you want to introduce yourself real quick? Again, I know you've been on the show before, but then after that, I'm totally cool with however you guys want to do it.
Yeah, sure. Well, thank you guys for having me back on the Alert Medic 1 podcast. My name's Tim Chizmar, and I'm pleased to be with you to talk about some of the changes we've made for 2024 in Maryland EMS. I'm the State EMS Medical Director in Maryland, and again, as Josh said, if you're from Maryland, this will definitely help you out, and even if you're not, hopefully we can give you some insights into why we made some of the changes we made.
Awesome. So looking at the updates in the beginning of the protocol, so for anyone that's ever wondered, if you want to find out real quick and easy what is different in the protocols and what's new, it's like in the first 5 pages. It's in the welcome letter. So I'd say let's hit probably, I think, what is the biggest change this year is the VFib pulses VTAC algorithm change.
Yeah,
that's pretty foundationally different from what we've done in the past, even though we've seen a lot of changes over the past 5 or 10 years. But this one is one that is going to change the game big time for all clinicians across the state. So, Doc, if you want to talk about how that came about and why we decided to go with this big change.
Yeah, no, thank you, Josh. We've, for many years, been looking for ways to improve upon our not just survival, but neurointact survival for all cardiac arrest patients. But we do know that the subset of patients that who present in VF and VT represent an area where we really ought to be able to save 50 to 75% of those patients based on what we've seen in some of the other jurisdictions out there. And our cardiac arrest survival rate, neurointact survival rate, has been kind of mediocre, to be honest. But we're dedicated toward improving that. So some of the bundles that we put together this year involve vector change defibrillation, dual sequential defibrillation, esmolol for VF storm, and considering early transport if you're within an eCPR capable facilities reach, generally within about 15 minutes. So I figured just talking about those at the outset might be helpful, and we can dive into each one as you'd like.
Okay. So I guess the big one of it all, let's dive into vector change and double sequential. So I know this comes from the dose VF trial by Cheskis et al. Coming out of Canada. That was the main driving force behind this. It was a groundbreaking study. We've talked about it numerous times on this podcast. If you haven't looked at it, take a look at it. It is, I'd say, revolutionary in the world of defibrillation techniques and what works well and what doesn't work so well, and kind of changes up the game. So what was the selling point, I guess, for Maryland to decide on this? And then in turn, what should agencies be looking for? Maybe clinicians and agencies be looking for it when it comes to deciding between double sequential and vector change.
Yeah, Josh. So I think the really Dr. Cheskis came to visit us personally and went over some of the key findings of his study. And I think that was very, very compelling hearing from him personally. I think right out of the gate, we should hit this the barrier, and that is a lot of people may believe that if they do dual sequential defibrillation, that they're going to risk harm to themselves, harm to the defibrillator. And as we broke into that and sort of understood the process a little bit better, the defibrillator really is charging, it's administering a shock over a period of time, and then it's closing. So that it doesn't receive shock back into the device after a certain period of time. And the way we set up the protocol is to be rather intentional and deliver the first shock with dual sequential, and then give a very brief 1-second pause to allow that first defibrillator to essentially close so that it won't receive the shock from the second device. So I want to make really clear that this is a sequential shock, not a simultaneous shock. And we're asking the clinician to use the same finger of the same hand to deliver both shocks using both machines side by side. But I think for a lot of folks, we may not always have two monitors at the scene. So the vector change option, I think, is particularly important. If you're on scene, you have a single cardiac monitor defibrillator, whether you start out anterolateral, so if your pad is placed anterior and anterolateral, or whether you start out with one anterior pad and one posterior pad, there's good data in Cheskis's study as well as other literature to say that we're not all exactly identical, that sometimes the vector of energy going through our heart needs to change in order to get the most effective defibrillation. So based on Cheskis and a couple of other pieces of literature, I think we've very clearly seen, as Cheskis has seen, that with cardiac arrests that are going on in the state now, even without having a formal vector change protocol, that there are some patients for whom the anterior-posterior approach or the anterolateral approach just frankly leads to a more effective defibrillation because of how the vector is traveling through the heart. So we set this up so that there's one monitor. Again, considering that vector change defibrillation is what we'd like folks to do, because sometimes it's just not possible to know exactly how that vector is traveling through an individual patient's heart.
Dr. Chizmar, is there any research to say there may be additional vectors in the future that may be of benefit to people?
Yeah, so the great thing about cardiac arrest is that it's got a ton of investment. People are looking at this all the time. And I think that it's still not a matter of settled science that anterolateral or anterior posterior placement is the optimal vector for an individual patient. So there is still some ongoing research. We didn't feel like the body of research was sufficient at this point to recommend beyond that at this point, Ken.
Yeah, on the vector change portion, I've done it once before. I take that back. I've done it twice now. One time was successful, other time was not. Now it was just recently. And to give the audience some thoughts on this better conduction through the heart and through the body tissue. So when I did my whole review on this first case, I did a grand rounds presentation. And if you ever go into your life pack and you print out your strips from when you delivered your shocks, it actually tells you your thoracic impedance threshold, or threshold of impedance, but basically the amount of energy it takes to go from one pad to the other. And it's cut in half from what the anterior lateral is. At least in that case it was around 112, 115, and the AP placement was about 60. So it doesn't have to go through as much, so it's a much more effective delivery of the electricity.
Yeah, I think that's a great point, Josh. And I think if you've got, again, if you've got patients of different body habitus, that's got to be one of the key factors as well. That you can expect changes in impedance between individual patients.
To kind of tie up the part on VF and vector change and double sequential, Doc, do you think most agencies are just going to be doing vector change, or do you think there's going to be a lot more double sequential across the state? What's your opinion on it?
So I think at first, where we've got a single defibrillator in more rural areas and not an organized chase system, we'll see more vector change. Where there are areas of organized chase systems, I think that second monitor will arrive because this is not right out of the gate. that we're doing dual sequential or vector change. What we're doing is delivering 3 standard shocks, as you would now, whether your agency, whether you start anterolateral or anterior posterior. If you still have only one monitor after that 3rd shock, changing the pad placement to whichever approach you're not currently using. And if you do have that 2nd monitor arrive after the 3rd shock, which I think in many of our suburban and urban areas, especially those with organized chase systems, we're going to have that 2nd cardiac monitor defibrillator there. Delivering that dual sequential shock, I think, is going to be a game changer for VFVT. It's very, very exciting. We've had a few jurisdictions pilot this already, a few with success. In fact, we had a recent case that was successful all the way through, starting with the dual sequential onto eCPR in the hospital. So this certainly will not be every single cardiac arrest, to answer your question, but for those that remain in persistent VF and VT, this can give us a couple different approaches to not just sit there and shock the same old way that we've always shocked 6, 7, 8 times, and then until we get a flat line, until we get an asystolic patient, which I think is probably one of the more frustrating things, because these patients are salvageable, right? I mean, you've got an edge when you get a persistent VF patient.
So, Dr. Chizmar, we've kind of beat around this, but I think it's important to point out this is not, the dual sequential defibrillation is not something you can do with an AED, right? This must be a manual defibrillator.
Right. So that's a good point, Ken. Cheskis did his work with 2 manual defibrillators. We actually posed the question to him as well. And in order to get the timing right, and we're trying to get those shocks as close as possible without being simultaneous, the recommendation is to use 2 cardiac monitor defibrillators and not try to mix and match an AED with a standard cardiac monitor defibrillator.
Does an AED doesn't automatically shock though, right? You still have to push the button.
Most of them are sort of I know we call them automated, but most of them are semi-automated in the sense that they'll analyze the rhythm and then stand by and wait for a person to push the button and chart and deliver the shock. So again, while it is theoretically possible, we wanted to really rely upon the results from Cheskis's work as closely as possible.
Okay.
Is there anyone that's trying to reproduce his work currently?
Not that I'm aware of. I'm certainly I know that obviously agencies are taking this on, but in terms of a research format, Moose, I'm not certain that I've seen a group of investigators.
Don't quote me on it, but I think there might be.
I'm sure there is.
I saw a comment or something somewhere about someone that's doing something similar, because I know there was some controversy over the Cheskis trial because it did not complete, and that was because of COVID. And so there was people that were calling a lot of the data into question because it didn't complete, it didn't get as many people as they thought, and there was limitations. But I think there may be someone, but it's like something sitting in the back of my mind.
I think the other thing worth just discussing, and Cheskis is pretty open with this as well, is that it's not always clear whether the VF and VT is refractory or it's recurrent. So in other words, if it's refractory, we never got them out of VF or VT with the first shock, or recurrent, we did get them out, but they went right back in to VF VT. And so sometimes it's very hard to tell. We were very intentional in the Maryland protocols to say persistent and not make a judgment on whether it's refractory or recurrent. So there's still a lot that we're trying to understand about the pathophysiology, but we certainly have seen cases that have done very well at terminating VF and VT. And certainly, in addition to changing our defibrillation strategy, we recognize that there's something called VF storm out there, that during a cardiac arrest, particularly in persistent VF VT, that we've got excess levels of catecholamine. We've got just adrenaline surging through the body. And for that reason, beyond the 5th shock, we make a recommendation for a beta blocker called esmolol, very brief-acting beta blocker, which again has been used. It's been used here in cases both in the hospital and out of the hospital, not with universal success, but with some success at terminating VF and VT that's otherwise been persistent.
Yeah, I know Montgomery County Hospital District, not Montgomery County, Maryland, Montgomery County Hospital District in Texas did a big study about using esmolol. Not big, but they did an in-house study about using esmolol in cardiac arrest and saw some pretty favorable results.
Yeah, and it's not necessarily that it has to be esmolol. Some investigators have used propranolol or metoprolol. The attractive part about esmolol is that it's very short on, very short off, and so if needed, it's not sticking around for long periods of time. And you're really just trying to interrupt that catechol surge for a brief second and allow the heart a chance to be defibrillated.
So, Doc, along the lines of medications and VFib and persistent and pulseless VTAC, we've had some changes. The big one would be the 1 milligram of epinephrine once, a single time, and another time if you have rearrest after ROSC. But other than that, one epi. And sitting here, we've all gone through so many variations of how much we give epi.
Right.
You know, whether it was 6 epis every 3 to 5 until the end of the arrest, to what it is right now, which is 4, and that'll stay in the PEA and asystole algorithm. But now we're moving to a single 1 milligram epinephrine. And Doc, if you give us some background of why that single one.
Yeah, so kind of along the lines of why we're reaching for the beta blocker in these patients. We know that particularly in VF and VT that's persistent, we can see just very high levels of catecholamine surge, and adding epinephrine to that is just sort of putting more fuel on that fire, for lack of a better word. The pathophys behind somebody that's in PEA or asystolic arrest and somebody that's in VF and VT, we're starting to understand that there's a lot of key difference there. So we're asking to limit in VF and VT to just a single dose of epinephrine and following right closely behind with amiodarone, not waiting, getting the antiarrhythmic on board early. Very different than our approach in PEA and asystole. But you are seeing, I think, across the board, a limitation to epinephrine that if you're going to give epinephrine, give it early, get that vasopressor effect out of it. But if that is not helping you to achieve ROSC, chances are that giving more and more epinephrine is not going to be helpful to you overall.
All right. So, is there a specific drug we should be giving first in cardiac arrest?
Yeah. So we wrote the protocol so that epi and amio are given back to back. We in the protocol wrote amiodarone first, followed immediately by epinephrine. The goal again is getting the antiarrhythmic on board early, and at least that first dose of epinephrine to get some vasopressor squeeze as well.
Cool. Drug wise, the rest or through the rest of the algorithm, there's the amio 150 again. That's actually going to be after your 4th shock via the algorithm, and the esmolol is coming after your 5th shock or 2nd alternative defibrillation technique shock as well.
Yep.
Mag is still in there for torsades. Calcium is still in there for suspected hyperkalemia arrest, and then bicarb is in there for sodium channel toxicity suspicion. Ken?
Sorry. Is magnesium still in there as a last stitch for your persistent VT arrest, or was that removed?
So the data on magnesium is actually strongest for polymorphic VT and VF as well, as opposed to monomorphic. You could still give magnesium, but the data is just not as strong on monomorphic VTAC. So it is left in there for its marginal benefit. And again, I think each medication that we're talking about in isolation, it's hard to parse apart exactly how effective each individual medication is, because in a lot of cases these are studied when they're all put together as well. So in many cases, we're studying a cardiac arrest where patients have received all these medicines, and then trying to tease out the individual effect of individual medicines on live cardiac arrest patients can be challenging. But the current takeaway from most of the literature is that the magnesium has some marginal benefit, obviously the most benefit in torsade, but also polymorphic VT and VF further down the line.
Okay. I think that's pretty sufficient. Oh, wait, we didn't talk about ECPR. Sorry. So ECPR is the final portion of this, or extracorporeal CPR is the next or final portion of this algorithm. So, Doc, if you want to cover what the indications are for going to an ECPR facility,
Sure.
And if you could, real quick, also say what the ECPR facilities are in the state.
Sure. So we admittedly got a little bit ahead of ourselves with ECPR capable centers. We do not have a formal designation process for ECPR capable centers. We have hospitals in the state and near the state borders that do ECPR or extracorporeal CPR ECMO for patients in cardiac arrest. So what the approach we've taken though is, instead of waiting on the designation process, was to move forward and say, look, we know at a few hospitals in the state and in the district that ECPR occurs, and those are Johns Hopkins Hospital, University of Maryland Hospital, and MedStar Washington Hospital Center. We know that they're able to get a patient onto ECPR pretty promptly. So we didn't want to wait until there was a formal designation process. We wanted to continue to move the protocols and move forward. With that said, however, in order to be a successful ECPR candidate, most hospitals will say that their criteria sort of lay out that you need to be within 30 minutes, be a witnessed arrest, and be on the machine, be on ECPR within about 30 minutes. So when we were crafting this with colleagues from across the state for EMS, we said a couple of things. If you're going to go to an ECPR center, you got to be close. And we roughly approximated that at about 15 minutes, allowing you transport time to get into the hospital, and also allow the hospital team time to cannulate them to get them on ECPR. We said before you start moving that you ought to have at least an effective way to ventilate the patient, whether that's a supraglottic or an endotracheal tube, as well as mechanical CPR device in place, so that we're not compromising compressions while we're moving the patient. Because we know that we can do effective CPR when we're still, but when we start moving, it becomes a little more challenging. So taking it from the top, we, again, work the cardiac arrest, high performance CPR, defibrillation, as you heard before. After that second shock, we're going to be thinking this person may be somebody that's going to go to an ECPR center. We're not going to move them yet, but we're going to be looking at these criteria. And again, if eventually we have an airway in place, mechanical CPR in place, and then the criteria, the demographic criteria, is a hybrid of what two of the hospitals in the area are using for ECPR, and that is an age and range from 13 to 60 years of age, witnessed arrest that receives bystander CPR, including if we as EMS witness that arrest, and an initial shockable rhythm, and transport time within 15 minutes. So 15 minutes or less to the closest ECPR capable hospital. So you got to meet a lot of criteria, but that is, really reality in 2024, that they're not generally going to put you on ECMO unless they have a high degree of confidence or at least some degree of confidence that you're going to do well.
Okay. Anything else we want to talk about with that protocol before moving on to another that I'll let Ken pick to talk about?
Well, I'm a big fan of airway issues and respiratory problems, so let's talk about the asthma COPD changes.
I thought you were going to go with a different protocol altogether, Ken, but I didn't give you enough credit. We'll get around to it. I'm not going to.
Okay.
So, yeah, asthma and COPD, I think we made some common sense changes. We got rid of some of these perfunctory consults, particularly at the paramedic level. So we've long held that we've tried to get rid of consults that really don't do anything, don't serve any purpose. At the paramedic level, you're able to give as much bronchodilator as the patient needs. And so after the second dose, overall, the only clinicians that'll still need to consult would be our friends, the CRTs and EMTs. And again, some of this is to make sure that we're considering other possibilities for the person's respiratory distress. But at the paramedic level, we removed the consult for continuous doses of albuterol or repeat doses of albuterol. We further removed the consultation for magnesium. The reason the consult was in for magnesium going back to 2016, 2017 was purely because magnesium has marginal benefit compared to the bronchodilators. So the thought process back then was put a consult on it so we don't get around to it until later on. I know that I trust everybody to know that bronchodilators are first line. and the magnesium comes later. So there was really not a need to maintain that at the paramedic level, to maintain that consult on magnesium as well. Go ahead, Ken. Sorry.
I'm sorry. No, I was just going to say, I thought you guys did a tremendous job in the protocol update video, making it clear that the magnesium sulfate was essentially the last ditch effort. The entire protocol should be applied prior to moving to magnesium. I also really like that the albuterol change was made because, you take someone to the ED who's got that status asthmaticus, and they're just wheezing away. And what's the ED do? They put them on, nebs nonstop, albuterol. And as a paramedic, I always felt, like, why can't I do that? That's totally in the scope of what I'm comfortable doing. And I think these were both very common sense changes, like you said, and I'm glad to see them made.
Yeah, you're exactly right. I mean, that's the first thing we're going to do, right? We're going to give them more albuterol if they're still wheezing. So inherent in that is that we're trusting that people are going to reassess and make sure that it's actually indicated, moving forward. But I think this is not a big leap to make.
I'm very happy that this happened. No, but all I was saying was, the principle of having a protocol that was administratively stopping someone because we just didn't trust our providers to be able to critically think really, really irritated me. So I'm very happy that we've changed that. And it's, in general, I think, a move that the protocol has been taking, a direction, I should say, of, treating our clinicians as those calculated, critically thinking clinicians. And are mistakes going to be made? Absolutely. But that's why the quality assurance process and the quality improvement process is there. Right. So, no, I also commend the protocol change.
Yeah.
No, thank
Spoken like a true administrator.
Since Moose kind of broached it, it definitely is. It's awesome to see the quote unquote "Mother May I" aspects of the Maryland protocols slowly ebbing away for the paramedics of the state. It's moved. I know Ken's been a medic longer than I and longer than Moose, and the things that he had to call for when he first became a medic compared to what now is night and day difference. And it's a night and day difference from when I became one 7 years ago. So
way back when, Ken, right? In the era
way
of stack
back when.
shots.
Hey, it's been almost 17 years since I got my CRT.
Crazy.
Yep, 15 since I got my P.
When
Are we
PCRs
recording
were chiseled
or is
into
this
stone.
part cut out?
Oh man, I hope it wasn't cut out because I wanted to keep my chisel comment. But okay.
I'll say what I was going to say later.
All right.
So I think that pretty well covers the asthma protocol. The big thing being that paramedics, you don't have to consult for your albuterol and your mag anymore. Just give the albuterol if the patient needs it. Don't worry about calling. Just do it. I think one of the big ones after that is probably the burns. The change in burns, going from the rule of nines to the Palmer method. I'm sure everyone that's listened to this has heard both of those ways to calculate total body surface area for burns. Rule of nines. Everyone's had to memorize those graphics and diagrams of the kid and the adult and dig it out of nowhere when you do your national registry test or do your FISDAP test in class or some other test during your time with your department or agency or something. But now we're going to the Palmer method. So, Doc, if you want to talk about the Palmer method and why we switched to it.
Yeah, so a couple of things. I think you may recall a few years, maybe last year or the year before that, we went back and really tried to pay attention to our fluid resuscitation. What we were getting from the feedback from the burn centers was essentially that we were providing too much fluid, that we were over resuscitating, and one of the reasons we were felt to be over resuscitating was over calculation or overestimation of the BSA burned. So as part of that effort, the rule of nines was sort of scrapped and in favor of the Palmer method. The other nice piece about the Palmer method is that instead of trying to calculate by regions of the body, because sometimes people aren't burned on an entire leg or an entire torso. Sometimes they have a little bit, an area of burn on their arm and one on their foot and one on their, one on the back. Sometimes it's not entire areas like the way the rule of nines is set up. It makes it a little bit easier to try to estimate all of that when you're totaling it all up, how much, what the percentage BSA is involved. So what we hope for is that this will lead to a little bit more accurate estimation of BSA, and also not lead us to provide excess fluid if possible. And also the sort of the last piece is in areas where patients don't have entire body areas burned, entire areas or regions of the body burned, and they have burns in multiple areas, that it may allow us to be a little more accurate there in our estimation. Finally, it's easy, right? Patient's hand, 1%. Don't have to memorize 18 and add 18 and 9 and 4.5. I mean, who doesn't love that?
I've used Palmer unofficially for years. I learned it in the Army, and I've seen it in multiple different CEs, and it's all, wherever you look on social media, every now and then it pops up. But like, it's just super simple. You just look at what's burned. You look at the patient's hand. Yes. Can you literally take the patient's hand and like figure out what it looks like on that portion of the body? Yes. But just visualize it in your eyes, that size on that burn. Easy. And then you actually can get, like you said, you can give an accurate number to the burn center when you consult. So you can tell them, oh, it's a 3% burn on the upper portion of the anterior chest. Your classic like pulled down boiling water or a cup of tea on the child. It always lands like right here on the top of their chest, but it's not always all their chest. It may just be centered. So you're not doing that whole chest. Just take their hand and figure it out.
Yeah, and I think the other part, although this wasn't a change from this for this year, is we really would not start fluid resuscitation until we get to 20% body surface area burned. The other key piece to keep in mind is these are second and third degree burns, not including just redness, isolated redness with a first degree burn. So if you've got 20% or more BSA, we're going to initiate fluid resuscitation. If not, we are not giving boluses of fluid, and again, in an effort to try to make sure that we're not over resuscitating the patient.
Awesome.
Yep.
Ken, Moose, you guys want to pick one out next?
While we're on that topic, can we talk about the hyperbaric chamber? Because this is a change that I have honestly been not the change, but this is a topic that has caused many people confusion and consternation over the years. I've got a burn patient who's got CO inhalation. Which hospital should I go to? And they end up usually calling, both, which hospital wants it. But now it's spelled out in the protocol where we're going.
Exactly right, Ken. Sometimes this can be really confusing. I mean, you're really trying to keep track of two things, right? Did this person have significant carbon monoxide exposure, or are they burned? So to try to separate these out and introduce a little bit of clarity, isolated smoke inhalation or isolated CO exposure without suspected thermal burns to the airway, we still want those patients to go to the hyperbaric medicine center. But any patient that has suspected thermal airway burns, really the more important priority, the more pressing time-sensitive injury are those thermal airway burns. Not to say that addressing the CO component is not important, but certainly we can continue to do that with high-flow oxygen. What's going to kill the patient first, though, is if they have significant thermal airway burns and we're not positioning them for success. So I try to think of it in sort of this way. For a long time, we've said if you have burns and trauma, go to the closest trauma center, right? So now we're introducing that other dimension in there with CO, trying to make this all fit together. If you have CO and burns, you're going to the burn center. So that as opposed to before, where it was sort of a toss up. It's like, as you said, Ken, do I go to the hyperbaric center? Do I go to the burn center? So in order of sort of what's going to kill the patient first, trauma, generally because they're in hemorrhagic shock, then the burns, then the CO, if you want to think of it in sort of a hierarchical way.
Thank you, Dr. Chizmar. Josh, do you have anything else on burns or hyperbaric?
No, I mean, not really. I'll be honest, I never really gave the hyperbaric center a whole lot of thought because of where I work. I work 45 minutes away from it. I'm only thinking about it for my CO patients, because my smoke inhalation patients, this has been talked about a lot. It can be difficult to assess a patient for airway burns early. We may not see indications. There are some things that are pretty clear cut that, like, see soot around the nose, there's mouth, inside the back of the mouth, but that's not always guaranteed. But at the same time, we can have a late onset. So, like, taking that 45-minute drive to Baltimore for me can be like a toss up of, am I going to be taking this airway halfway up the way on 95? And my jurisdiction doesn't practice RSI. So now I am having a really interesting day, you know? So it's just something I never really thought about except for CO patients. And while I haven't done it, people on my shift have driven to Baltimore for CO patients. So, but
Yeah,
this
Josh,
gives clarification though now.
Yeah, we're really trying to clear up that intersection of burns and CO. But as you said, there are patients for whom there is still benefit. Patients that have significant CO exposure, that have seizures, for instance, or they're unconscious. This can be very, very helpful to them to sort of minimize those CO levels as soon as possible, and minimize the neurologic sequelae. Certainly, if it's a marginal CO level, high flow oxygen is going to be the name of the game. But in that select patient population where they've got significant smoke inhalation, CO exposure, I should say, still do keep that in mind, because that is an excellent resource that we've got available in the state. Sometimes it's a little farther to get to, but we really just wanted to set out and clarify that intersection between burns and CO with this most recent change.
Okay.
Awesome.
Yeah.
I think a good protocol to move on to would be the changes or the addition of indications for droperidol.
That's what I was going to vote for next.
Well, see, Ken, that was the one I thought you were going to go with from the start.
Oh, okay. No, it wasn't first and foremost on my mind, but it is a very cool protocol, and I'm a big fan of it because I don't like getting puked on, and droperidol is a very versatile drug. So let's talk about it.
Yeah, droperidol, as you said, is a great drug. It was put away essentially for 2 decades and is recently reemerging for both agitation, but also nausea and vomiting. It's been used in operating room settings for many, many years at very low dose. It's very effective for nausea and vomiting. Even for the anesthesiologist will use it at doses as low as 0.625 milligrams IV. Again, very effective. We put it in, so we had droperidol in there for agitation. These kind of protocol changes are always nice. Finding another indication that we can be effective with a drug that we've already got in the protocol in the formulary. What we did with this was kind of split it out 2 ways. For nausea and vomiting that we suspect due to cannabinoid hyperemesis, because we know that never happens, or migraines also never happens. Consider that as a first-line drug. Cyclic vomiting, migraines, cannabinoid hyperemesis, considered as a first-line drug. And again, I told you before, you can use lower doses, but we started at 1.25 milligrams. And then if the patient has continued symptoms, switching over to Zofran. Unfortunately, we don't always understand which med is going to work best for an individual patient first. So we wanted to maintain that ability to switch to a second agent if the droperidol in this case was not effective. So that's sort of the indication we added for nausea and vomiting, specifically if we think it's due to a migraine, cannabinoid hyperemesis, or cyclic vomiting syndrome. And then we also kept droperidol in there as a second-line med if we give a dose of Zofran 8 milligrams and it's not effective, to give another agent sort of in reverse, to give a dose of droperidol. So we tried to introduce some flexibility, some versatility. Still, obviously, trying to remain cognizant of not prolonging the QTC, which all of these antiemetics do to some degree. Here's a quiz for you guys. Do you guys know how to pick out a person that has cannabinoid hyperemesis most likely versus just nausea and vomiting? What's that?
They're in a hot shower.
They're in the hot shower. See, you knew it already. I'm not going to ask you how you knew that. If it's relieved with a hot shower, or if they happen to get their hands on some hot peppers, if it's relieved with capsaicin.
Really?
So
I didn't know that one.
People. So I didn't put this one in the protocol book at the risk of mocking, but there are some people that will try topical capsaicin because this is really a histamine phenomenon, and trying to balance histamine levels out. So I those two things really, if they're being a little bit coy about their history of cannabis use, can be helpful at picking these patients out.
Okay, awesome. I can't wait to end up using Geparidol for nausea, vomiting. Something new, something we've been treating for ages with the same thing over and over again. Now we get to treat it with something else and see how well it works. I know we've all had those patients that are actively vomiting that we give it Zofran IV and that doesn't do anything. People say that Zofran, once you're vomiting, not too effective. But
maybe you'll have a cleaner unit and less fewer basins to throw away when we're done with it all, right?
Very true. I would say the last big, I won't even say it's big because it is kind of limited, but Levofed. So it is a little limited, but it is a big ALS intervention if you're able to do it. So, just a quick rundown. It is only for systems that are using pumps. Okay, this is not a gravity-fed presser that we're going to be doing. This is pump only. So if your agency is not using pumps, unfortunately, you are not using Levo right now. So, Doc, if you want to talk about bringing in Levo and then the reason why it is limited to pump only.
Yeah, so we were very creative with epinephrine and really trying to do the calculations so that it could be used with and without a pump. With Levofed, the brand name Levofed, generic name norepinephrine, really the math and the titration don't really work out. So we really had a lot of concern about patient safety in getting the dose correct without a pump. And that's really the primary reason why there's a requirement for the pump for norepinephrine. But we felt that norepinephrine was important as a first-line vasopressor. There's a lot of data, of course, for norepinephrine as a first-line vasopressor in various shock states, including septic shock, which we certainly see a lot of, particularly in the adult population. So we put it in 18 and older. If there is a pump available, and essentially the data across scientific studies time after time for various shock states, whether it's septic shock, cardiogenic shock, it really shows us time and again that norepinephrine ought to be the first line in terms of not only morbidity and mortality, but also the risk of complications and arrhythmia. As many of us got an EMS, the only vasopressor we had was dopamine. Looking at that through the years, we've seen that dopamine really requires you to have your own endogenous stores of catecholamines, and the dopamine is sort of an indirect pressor. It also is more arrhythmogenic, so you're more likely to get arrhythmias with it, and you're less likely to also achieve a reasonable MAP, 60, 65, or in some shock states like neurogenic shock, where you're shooting for a higher MAP, your odds of achieving that MAP are just not there the same way as they are with epinephrine, or particularly norepinephrine. So again, we have at least a handful of jurisdictions that either have pumps already or are in the process of bringing pumps online. And that opens up really a ton of possibilities in terms of meds and how we can deliver meds safely. And norepinephrine is certainly going to be one of those use cases.
Yeah, and speaking of the bringing of pumps into systems, there's even a new part of the protocols that directly talks about how those pumps should be programmed and what dosage ranges they should be doing.
Yeah, so we put that in there really just to try to address that and let all the jurisdictions and all the clinicians know which medications in the Maryland Medical Formulary could be used on a pump. The other attractive piece about the pump is that you're not necessarily memorizing dosage range, the actual individual dosage. What you're doing is programming the pump library. You're putting the patient's weight in or estimated weight, and then the device is calculating that Now, you do, of course, need to know the relative titration for the drug that you're doing. So you're not off the hook entirely for knowing something about this, but that's something you can easily look up. Your starting point, though, it's very nice. I know that several of us have seen the pumps also get smaller with time and become more affordable. So as all these factors have converged, jurisdictions have been able to pull this off, which is great. I think it's great. It opens up our formulary. It opens up what we can do for patients.
Yeah. So my agency uses pumps. I've talked about it before on the podcast and on the Instagram, and it definitely is I think it's a game changer. I think it is the next step up in like what your EMS agency can do. There's a lot of talk of like, well, the hospital, it brings us on par with the hospital, even though you'll see a lot of times in the ER, maybe they're not using a pump for stuff, but we're using pumps for epi, calcium, our D10 drips, our TXA, all this stuff. It delivers everything at the rate that it's supposed to without you having to tax your brain to figure it out. And I always equate it to just a couple months before we got pumps. I remember doing epi drip, and as we're bumping down the road, it would drip, 5 drips at once, and then we'd drip at the right rate, and then it would jostle again, and another couple would come out all at once. And with this, it is constantly at the same rate, regardless of what you're doing. As long as there's no occlusions upstream or downstream, it will pump at the right amount, at the right rate consistently without you having to worry about it. Fire and forget. Just listen for an alarm and fix the alarm when it comes.
That's the key, is troubleshooting the alarm. So, if you're a physician like me, when you're in the hospital, you never touch the nurse's pump. The only button you know how to push is the one that silences the alarms, and then you go get the nurse. So little shot at doctors there for everybody.
So there's a bunch of other very small things, modifications to existing protocols. I'm sure Moose wants to talk about a very specific protocol.
Can we talk about the change to diltiazem just real quick?
Oh, that's a good one. Yeah.
I just think it bears mention. The protocol now specifies that patients with an EF of less than 30% should get a reduced rate or dose of diltiazem. So I just wanted to throw that out there for the good doctor.
Yeah. So great point. As we try to take care of cardiac patients, AFib with RVR and CHF are going to converge. And where possible, when the EF is less than 30%, we have a history of congestive heart failure. These are the patients that sometimes will become hypotensive. So cutting that dose down, being ready with calcium chloride if we do give the small dose and the patient's blood pressure drops. This really comes from continuous feedback from throughout the system. That we needed to make sure that we're making everybody aware of that risk, a little bit of elevated risk.
So, to add to that, a provider or a clinician might ask you, how do I know if my patient has an EF that low, right? And because sometimes certainly we won't. And that's why your assessment and history comes into play, right? I mean, from talking to your patient. I forget what episode it was, Josh. I think it was when Mike was on, but we kind of went into a deep dive of why cutting out a heart rate for a patient that has a reduced cardiac output, is so bad, right? So maybe we can post that once I remember what episode that was. But the big thing I want to stress here is when we say be ready to give calcium, that doesn't mean the calcium is in a bag, right? It should be at the bedside, right? It should be at the bedside. Maybe you're not breaking the box because that'll really piss off your supply officer. But it needs to be next to you, and you need to be assessing your blood pressure, the patient's blood pressure and their mental status consistently. I'm always okay with giving a plug for N-Title too, as a early indicator of a drop in perfusion. Certainly, N-Title is not only for respiratory patients, right? I think we've established that clearly on the podcast already. But have that next to you, within reach. Check your blood pressure immediately and consistently. And if they drop, that is the antidote, right? Because we're going to be able to mitigate a lot of negative outcomes if we just give that calcium. And there is no easy answer. Sometimes you will have that, you can do everything right and still have that significant hypotension, but that's why the antidote is there to treat accordingly.
Yeah, Moose, you brought up a great point there. Just to emphasize it, we see a lot of patients with congestive heart failure. We think of it as just being one size fits all, but there is actually congestive heart failure with preserved EF and congestive heart failure with reduced EF. Long ago, when I learned these, I learned reduced EF as systolic heart failure and preserved EF as diastolic heart failure. But now the preferred terms are preserved EF, so normal EF 40, 50%, or reduced EF less than 30%. We're used to seeing the hypertensive preserved EF CHF patients. Those are the patients we're used to giving, to starting on CPAP, giving IV nitro. Those are the patients that we most commonly think of, I think, when we see CHF. But there's also a proportion of patients who have systolic CHF or CHF with a reduced ejection fraction. These patients are not going to be your hypertensives. Generally, these are going to be CHF patients with lower blood pressures or borderline blood pressures. So if we come along with that diltiazem, negative inotrope, they're dependent on that heart rate to keep their cardiac output up. And they can't modulate their stroke volume because they've got congestive heart failure with reduced EF, right? So heart rate and stroke volume together are what give you your cardiac output. So I'm not sure about your other episode, but the long and short of that is that's why we want to really exercise some caution with diltiazem in these reduced EF patients.
Awesome.
Yeah, we can talk about it. So even though Josh called it a small change, I would disagree. So certainly there's a couple of things in here, right, that I think are pretty. When I think about protocol changes, we always think about like the new drug, the new intervention, but often when we talk to like our hospital partners and our other colleagues in healthcare, there's certainly systemic changes that we can make that improve the care of all of our patients. And one of those things that I was proud to introduce with colleagues from one of the major departments in Maryland and one of the major emergency departments in Maryland was the language line, where if a perceived language barrier is present, you should be using your jurisdictional approved language line or whatever resource you guys have. I know it seems basic to many of us, but certainly there's been cases where it has not been used. Thus, the reason we've introduced the protocol. Certainly near and dear to me as someone who has seen personally, someone very close to my family have a negative interaction with EMS when I was younger because of the fact that they just refused to acknowledge that the person, my family member, spoke another language and did not speak English. This was very near and dear to me, so I'm happy we were able to get that through the committee and pass and accepted by the board. Another, I think it's a big add. It's the addition of rocuronium for RSI. That's huge. I think. Because the fact that we were dealing with only a very short acting or a very long acting paralytic, I think that's big. And then the other one I wanted to talk about, which I know we're coming up on the hour. So, Dr. Chizmar, there was a last protocol that we wanted to talk about, which was regarding needle decompression in pediatrics. So, do you mind just expanding on that a bit?
Sure. So just briefly, for adult patients and for larger pediatric patients, the 3.25 inch 14 gauge catheter continues to be recommended. For our patients that are under 4 years of age, these are patients who we know their anatomy is certainly obviously different. It's much smaller. We're recommending use of a standard 16 gauge angiocatheter, a standard 16 gauge IV catheter, as you would find on any EMS unit out there. So a standard 16 gauge IV catheter for patients less than 4 years of age, and for patients that are older than 4 years of age. 4 years of age and older. Let me do that again. For patients that are 4 years of age and older, we would go to the standard 3.25 inch 14 gauge catheter, standard needle decompression needle, for those patients that are 4 years of age or older. In terms of placement, for patients who are younger, our pediatric patients, who are under the age of 15. We'd still like to use the second intercostal space, mid-clavicular line on the anterior chest wall for patients 15 years of age or older, using the anterior axillary line essentially on the lateral, the side of the chest, is more effective, and less risk of complication there.
Cool. Thank you.
Okay. So hopefully, listening, whether you're a Maryland provider or not, you got something out of this episode, some clarification, maybe some insight to some new protocols. For the Maryland providers out there, this does not suffice for your Maryland protocol update. Still go through the online training center on mims.org and complete it. It's quick. It's easy. It's painless. You can get it done in like an hour. Okay. So just get it done. Make sure your training officer knows it's done and doesn't have to harp on you for it, because we all know that happens this time of year, every year. So, Dr. Chizmar, thank you very much for coming on again
Thank
to
you.
talk about the protocols and sharing the insight from the state perspective and your perspective on why these protocols were added, modified, and changed for 2024.
Thank you guys very much for having me on.
No problem, Doc. So, everyone else out there, thank you for listening. If you're not already following us on Instagram, follow us on Instagram at AlertMedic1. Put out some content weekly. And thank you for listening, wherever you are. Have a good night, good morning, good evening, and be safe. See ya.